really speak about some different aspects and sort of some of the different concepts that we have and how we've built over the years, concepts that we've learned and then developed into more challenging type of situations. So I'll be speaking a little bit more about some of these more difficult situations. I'm here on Tuesdays at NYU, so this is sort of my second home. I know Ken Beecham's here, so I've known Ken for about 25 years, and I've just had my 20-year sort of recognition as far as being a teacher here. So it's a lot of fun being at the university, and I certainly have learned a lot. We do have a team practice, so I don't do surgery, but we do sort of interact quite a bit, and we also have some good lab technicians. So without their help, Adam's been a great friend, and I've known him for over 20 years. He's actually the only real ceramist that I've had over the years, and I know Ernesto has some great people down at Penn as well, and we do need all these lab technicians to help us with our cause. Well, let's talk about some of these concepts that we have in regards to this, and I'd like to focus the real presentation more on multiple implants in the aesthetic zone. I think that's one of the greatest challenges we have and sort of how we've evolved from single teeth now to multiple teeth. I think that's really one of the key elements. And the question is whether can we place two adjacent implants simultaneously together in the aesthetic zone, or the more challenging central-lateral situation, maybe placing two implants there, or consider doing Pontics in relation to that. And Maurice obviously has done a lot of work in Pontics, and his recent papers with partial extraction therapy with Howie Gluckman talking about using Pontics. And Pontics is sort of a forgotten thing, but I think it's a very valuable aspect and treatment modality that we have in aesthetic dentistry. So I'd like to talk about hard and soft tissue considerations in regards to this, as well as combining a lot of that information historically with what we know with immediate implant placement and immediate tooth replacement therapy. And I think that's really an important concept. We'll talk about actual treatment. So again, in about 40, 45 minutes, we'll talk about some of the treatment aspects and some of the nuances associated with that, and then tie up the conclusions. The conclusions may have more questions than answers, but I think that's sort of an important part of what are we looking for in the future and some of the aspects associated with that as well. So let's talk about some of the hard and soft tissue considerations. And again, Team Atlanta has done quite a bit of this work with my other partner, Dennis Tarnow. Now, these are some of the problems, obviously, with multiple implants placed in the aesthetic zone. It's not uncommon that you see loss of midfacial tissue as well as interproximal tissue. The left patient obviously has 4 implants consecutively placed. The patient on the right has a central and lateral situation. And so these become some of the issues. Now, the problem associated with this is that a lot of people show implants placed in the aesthetic zone, and they show some form of a gingival scallop, but that gingival scallop quantitatively is usually not enough. A lot of the studies done by John Coyce and Frank Spear talk about the range being about 3.8 to 4.5 millimeters, depending upon the tooth site, and we did some of those studies as well. But as an aggregate, the papilla height is roughly 40% the length of the tooth from the gingival zenith moving incisal. So it's really not enough just to have a gingival scallop. It's really the quantity of the gingival scallop. And hence, when we look at patients like this, we want to say, well, is that gingival scallop really the correct quantitative measurement or the proper height? It's just not enough to have, some form of scallop. And obviously, in this really bad situation, they have a negative papilla height and really no bearing of scallop at all. So it's not just a gingival scallop, but it's the quantity of the gingival scallop. I think that's important. Now, again, a lot of this work in relation to, say, non-platform switch implants looked at inter-implant distance in regards to bone preservation when we're talking about multiple implants or adjacent implants next to one another. And my partner, Dennis Tarnow, had done a lot of this work, and hence a lot of people quote his 3 millimeter rule. And I think Jomi just published something that talked about the top 100 articles in the history or the annals of implantology. Danny Boozer, who's good friends with Maurice and Henry and David, spoke at their symposium, their World Conference, and won an award. Danny Boozer is probably one of the highest on the list because he's probably done the most amount of articles. But in fact, Dennis Tarnow had about 3 papers. And one of them was this inter-implant distance paper, I believe. So this, we all know, is very relevant, but this is on non-platform switched implants. But if you look back, it's this concept of inter-implant distance he did with Steve Wallace and Seng-Chung Cho here at NYU. The problems that we faced was that even though we had the proper amount of inter-implant distance to preserve the interproximal crest of bone, we usually ended up with a very long proximal contact, and we had a very short papilla. And that was the clinical reality. Hence, again, in this situation, Team Atlanta also went back and looked with Dennis on this data. And this is a very well-known paper as well that talks about, well, if you really looked at the soft tissue height relative to the crest of bone on adjacent implants, they found that almost 3/4 of the sites fell within a range of 3 to 4 millimeters, hence the mean average of about 3.5. And I think that's a very well-known study that talks about, well, what's the height of the soft tissue over the crest of bone against adjacent implants? And it's about 1 to 1.5 millimeters less in height than compared to natural teeth. So this is a pretty well-known study. Now, this is another paper I probably need to speak to Maurice about, and maybe Ernesto, is that if you look at this paper, it's looked retrospectively. And the date of when the paper was published was the time that Joe Kahn actually reported about immediate implant therapy. So I'd have to probably say that all these sites were done in a delayed protocol, because Joe Kahn published his paper in 2003, and this paper was published in 2003. So this is probably on delayed sites. The question is, could we improve this if we looked at immediate sites? And I think that's something for the future. But in delayed sites, it's about 3.5 millimeters, about 1 to 1.5 less than we would normally find. Now, one of the key elements, as we all know, is that the tooth offers supracrestal attachment. And that's why on single teeth or implants next to natural teeth, we always have a higher papilla. It's about 4.5 to 5 millimeters, because it's the tooth that offers the supracrestal fibers. That's about 4.5. And again, between implants, it's subcrestal, hence it's about 3.5. So that's the data that we know from the studies. So like I said, you know, between teeth, it's at least 1 millimeter to 1.5 millimeters greater in height. And if you have a highly scalloped gingival form, this could be an aesthetic problem for patients. Well, if you now look at, say, platform switching and what platform switching can do, the concept of platform switching is obviously moving the zone of irritation more proximally, and then Dennis did some of these studies as well with the Borg group to actually look at, well, what happens in regards to distance between implants. Could implants be placed closer together and still preserve the crest of bone? Because this horizontal zone of irritation would have less of an influence. And hence, they found that, yes, you could place implants less than 3 millimeters between one another. As David Garber always says, the bone sets the tone, but the tissue is the issue. But the tissue actually protects the bone. I think that's a very important concept that's recently been elucidated by Thomas Linkovičius in Lithuania. I actually visited Thomas's office, and they have a very sophisticated practice there. And Thomas by himself, who also restores, places about 800 implants by himself. His partner, who I met, who's an oral surgeon, who I can't pronounce his name, his English is not very good, but he did disclose to me that he himself places 3,000 by himself. That is a lot. Maybe then he can afford a vineyard as well, placing 3,000 implants a year. Well, Linkovičius' studies are very important because if the tissue is important to protect the bone, Linkovičius said vertical tissue thickness or implant depth, which is another way of saying it, you have to have at least 3 millimeters in height or implant depth. It's not unlike the dentogingival complex around teeth, and we all know all the studies done by John Kois and Orban on this matter. For instance, let's take patients that I have treated in my own practice with, I think, with some very competent surgeons. And as Linkovičius said, that bone preservation is a function of tissue thickness. And I'm going to try to tie it together because if we're talking about adjacent implants, we want to preserve bone and soft tissue. So what Linkovičius is basically saying is that if you have less than 3 millimeters, you could lose bone, and hence you could have some problems. Here are 2 implants in the posterior mandible, healed, ridged. Obviously, it says 2 on these healing abutments, so you'd all agree that the tissue is less than 2 millimeters. If you disconnect them, you could actually see that there are different levels and different heights. But this is the real bottom line. These are the radiographs. And what's interesting to note is that that implant that's placed not as deep actually seems to have more bone loss than the implant that's placed deeper. And all these concepts about the connection being an irritant, it's very funny. You would obviously try to believe that the implants placed deeper or the connection that's placed deeper actually would have more bone loss. In fact, it has less. And then if you actually look at, then say, where those connections are, but where the bone actually ends up, the bone actually ends up relative to the soft tissue crest. And hence, Linkovis's studies really bring a different light to the whole concept, because he's basically saying that implants should be placed relative to the soft tissue crest, not the bone crest. And that is a total big game changer, because if you follow up on patients such as this, you can clearly see that implant that's actually placed deeper, that has thicker tissue, actually has less bone loss. So it really coordinates with Linkovis quite a bit. Well, how about this patient? And actually, the previous case was on non-platform switched implants. Well, how about this patient? This is another patient in our practice that I treated with my partners. And you can see here, this patient has thicker tissue relative to the implant placement. And as you can see here, there's bleeding, and which some of Abramson's work show that. Again, it's a non-platform switched implant. It's the same design as the previous case type. And this patient was a very difficult patient. I probably had to disconnect that 8 times in order to get the right shade for that lateral incisor. She was very highly aesthetically demanding. And you can look at this patient and say, well, it's non-platform switched, yet look at where the crest of bone is relative to the connection. So these are my patients in my practice, and it really conforms to what Linkovis says. So I'm a big believer that implants should be placed relative to the soft tissue crest, not the bone crest. And maybe implant design doesn't have anything to do with anything if the tissue is thin or thick. So that's sort of an interesting situation. Again, if it's less than 2 millimeters, again, even if it's platform switch, you will lose bone. And that's where we'd probably want it in the posterior mandible, where the tissue is really thin, and hence you want to preserve all the bone that you possibly could have. So it seems that Linkovis studies are pretty strong in this direction. The real question, where is the biologic with, more importantly, the dentogingival complex? Because in a healed ridge, you haven't put a tooth there, and once you restore a tooth, you have to factor in sulcus depth. And that's always a piece that we're always forgetting. That's an extra millimeter. So that's something that we have to think about. Well, this is a really interesting paper that just came out from Ron Nevin's group with the Borg group in Barcelona. And they said, well, what's really then the value of platform switching? If platform switching, maybe helps with inter-implant distance, but if the tissue's still thin, you'll still lose bone, what's the real value with platform switching? And the key is that they really elucidated this very, very clearly in the paper. And they said if the tissue is thick enough or the implant's placed deep enough, then it allows the tissue to grow over the platform, and hence you could then create the seal. And then the seal would be potentially resistant to multiple disconnections, because the reality is sometimes we can't always do one abutment one time or do the final restoration one time. And this is a perfect example. If you look at this particular patient, this is the prosthetic platform. And if you look after healing, about 4 months of healing, you will notice that the tissue has grown completely around the platform. That's what Nevin's paper basically says, and also Lyndon Cooper saying that you have to place implants at the proper depth. The good news with post-extraction socket implants, we usually place the implant deep enough. And hence, if you could create this seal, it gives you tissue stability over time, as seen on the radiograph. So this is a very, very important concept, and this recent paper in PRD really discussed this really, really well. Again, if you look at, say, this situation, the right central is an immediate situation, and the left one is a delayed situation. And then you could see here on Rex-ray, you can clearly see the one that's immediate, that's placed deeper, clearly has this concept of a seal. The one that was placed too shallow obviously has bone loss because it's formation of the dentogingival complex. Now, what I could probably do here standing in front of you is feed you some propaganda and say to you, not to say that we have propaganda in CNN, MSNBC, or Fox News. It's like 3 different countries. But the bottom line is I could feed you propaganda to say, you see, it's really about the platform switch because this one's not platform switched. That is nonsense. It has nothing to do with that. It's about the concept of creating the seal. Does the platform switch give you that opportunity? Yes. But I showed you the other case that was not platform switched with about 8 disconnections that just looked just as good in the X-ray. And it's sort of a funny sidebar. Maurice could probably appreciate this because we just did a preclinical study with Ron Nevins. And he said to me, he looked at me, and he looked at the company that's sponsoring the study, and he sort of chuckled. You know, he's a funny guy if you never really get to know him. He has a very interesting form of humor. And he looked squarely in my eyes and the manufacturer's eyes, and he says, what do you want out of this study? Do you want science? Do you want propaganda, hee-hee? Or do you want a little bit of both? Editor-in-chief of PRD, very powerful man. Interesting. We do have propaganda out there. Well, this says it all. These papers basically says, okay, well, what is really platform switch doing? I just told you if the tissue's thin, it doesn't work. But what is really platform switching doing for you? The bottom line is these studies looked at multiple disconnections versus one abutment one time. They found that one abutment one time was the control, multiple disconnections was the test, and they found that, and these are 3 different studies, that as an aggregate, they found over a 3-year period that with multiple disconnections, or the multiple disconnection group, they lost about 0.2 of a millimeter more bone over 3 years. And I say to you, on a 15 millimeter or 13 millimeter implant, is that clinically relevant? And the answer is probably not. So I love platform switching. If used properly, it may be able to actually preserve the bone and potentially the tissue. So we use it, but you have to use it the right way. And that may help when you're talking about multiple implants. The strategy of multiple implants is that you have to do everything you possibly can. Here, if you look at this inter-implant distance is less than 2, and this one's probably less than 1. These were done as a one abutment, one time protocol. This was 4 disconnections. So clearly you can see the concept that I just explained to you may preserve more hard tissue over time. And what was very interesting about this one patient that sort of confused me is that this is the clinicals of those x-rays on that patient. And once I saw the clinicals, I was totally confused because I thought that this concept would maybe benefit in regards to multiple implants. But you can clearly see here the tissue contour is still fairly flat. Maybe in the posterior area it's a little bit flatter, but still it didn't sort of match up to those great x-rays that you see. So this is sort of a quandary, which then leads us to believe that, well, maybe if we can employ immediate therapy, maybe we could overcome some of these challenges knowing the past history, but use immediate therapy to help us in this cause. And we know, again, with immediate therapy, immediate tooth replacement therapy, it's been well documented since Peter Worley, Joe Kahn in 2003, then Mike Block as well in 2009. The real key with immediate therapy is really about preservation. And when we do total tooth replacement therapy, we're really talking about preserving anything because we're just not replacing the root of the tooth, we're also replacing the clinical crown. And I think the concept of not disturbing what's there, that's truly our philosophy. If you look at what Maurice is doing, he's also believing that you're trying to preserve everything that's there, and I think we share that same vision. If it's there, leave it alone. Now, again, what about the horizontal thickness if we're talking about soft tissue? Like I said, I was a little bit surprised about the soft tissue numbers, and the key is that if you extracted a tooth and then placed an implant, the real question is not the vertical distance of the dentogingival complex, but the horizontal thickness. I think that's the key. Now, these are all the studies that have actually measured untreated tissue, roughly 2 millimeters from the free gingival margin. And all these studies say that if you just extract a tooth and place an implant, and you measure the horizontal thickness of the dentogingival complex 2 millimeters from the free gingival margin, the tissue is about 1.5 millimeters. And I can tell you for a fact, 1.5 doesn't cut it, because of all of Ronnie Young's studies basically say you need 2 to 3 to block out, say, a gray abutment. So these are some of the studies that look at that. Now, the real question then becomes, well, what can we do at the time of tooth extraction and employ immediate therapy to enhance the tissue? And this is the studies we had done with Team Atlanta. The concept, the dual zone concept, was a very good one. We had the concept paper and compendium, then we also did the studies that looked at this. And basically, the concept talks about intentionally grafting the bone zone and the soft tissue zone, and then contain the graft with the provisional, and then wait for healing and maturation, and then make your impression. What we found in these studies is that we had the ability to thicken the tissue. We did do these studies looking at some of these outcomes, and Joe Kahn also looked at connective tissue grafting the tissue zone. And so again, if we looked at, say, what Joe Kahn had done, and we compared our data from the dual zone study looking at soft tissue thickness with a graft, with a bone graft versus just a connective tissue graft, we did find that if we measured 2 millimeters from the free gingival margin, both techniques basically thicken or enhance this untreated tissue by about 1 millimeter. So Joe Kahn places a connective tissue graft in the tissue zone, we place a bone graft. And Dennis just feels it's a little simpler to do the bone graft. You can do a connective tissue graft, but we're finding that we don't have to do it quite as often. So at the time of tooth extraction, immediate therapy, we have ways that we can manage this and handle this. What we have found is that a small particle mineralized cancellous or cortical cancellous allograft of a particle size of about 1/4 millimeter to 1/2 millimeter in diameter seems to work the best. And we want something that's mineralized but has the ability to be reabsorbed and potentially be replaced by soft tissue. Now, then the question becomes, well, what is the height of the soft tissue when we start thinking about the scallop and the soft tissue height and all these numbers from what Frank Spear talked about as well as Dennis? The problem is that the soft tissue height that we're trying to accomplish could be as high as up to maybe 8 millimeters in height because of the scallop, where the implant's placed at the bone crest, and what the soft tissue height is. It's just basically a matter of numbers. So hence, it could be, say, 7.5 to 8 millimeters in height, and that's something that you have to think about. So enhancing the tissue becomes important because you want that tissue to hold in place. The real then next question is, well, what is the potential of these soft tissues? If you look at this image over here, it clearly shows a patient that doesn't have a contact. And Dennis Tarnow in 1992 said that you don't have a contact, you don't have a papilla. But if you look at this papilla, it's about 40% the length of the tooth, and there's no contact. And hence, you would probably say, well, what is the potential of these supracrestal gingival fibers? Because there's no contact, and theoretically, there shouldn't be a papilla between those two teeth. But there is. So that's really sort of an intriguing concept, because then if this tissue has the potential to hold its form, could we then capture it at the time of tooth extraction? I think that's the key. So if I go back to Dennis's paper in 1992 that talked about the presence or the absence, I would look at this data as my glass being either half full or half empty. It's all a matter of perspective. Now, if you're a pessimist, you say it's half empty, because he showed that at 5 millimeters, he basically had half the papilla were not present. But if my half was half full, I would say, well, even at 5 millimeters, 50% of the time, you still had the papilla. You understand what I'm saying? It's just the way that you look at the data. So I thought that's sort of an interesting thing. So don't forget that at 5 millimeters, or beyond 5 millimeters, at 6 millimeters, he still had half the papilla fill. And remember what I said, we need to get close to 7 or 7.5. And even at 7, he dropped off where he lost 70% of the papilla, but he still had 30%, even at 7. So I think that's a really interesting way of looking at the data. And actually, if you look at the data that looks at implants, the papilla height between implants, you could see here that still a fair number of majority of patients, again, were sort of at this 4 millimeter mark, but there were even patients at 5, 6, and even 7 millimeters. So the question then becomes, if the numbers are sort of in the data set and we're trying to reach more to that 7 millimeter mark, the potential is there. If they said that at 7 millimeters they had 0 sites, then I would be a little bit despondent. But clearly, looking back at some of this data and analyzing it, you can clearly see that there are some of these numbers. So how can we then employ immediate therapy, look at some of this data, and maybe make it used to our best advantage? I think that's the key. And I truly believe that if we employ immediate therapy, we have a better opportunity to preserve the interproximal papilla with immediate protocols. So let's take a look at, say, the patient that has two adjacent implants next to each other in the aesthetic zone. Now, again, some of the techniques that are published is some of the partial extraction therapies. Joe Kahn published this, talking about the interproximal socket shield. So it's carrying the socket shield more to the interproximal area. So Joe Kahn showed that maybe this is a good strategy in being able to preserve the tissue in between teeth. He also talked about a sequential protocol, meaning that you extract the tooth first, treat it either with a provisional or a definitive restoration, and then go back later on over time to treat the adjacent tooth. So you have the best opportunity in sequence to preserve the tissue. So Joe Kahn also talked about this as well, also using immediate therapy as a protocol. And then Riccardo Matrani also showing 4 anterior implants placed simultaneously with an immediate protocol. So clearly, there's some data to say that with immediate therapy, you may have the best opportunity to potentially preserve the interproximal papilla. So if I take a patient like this, Kristen, and I don't have all her final case done, but I have it pretty much, and I had a case done in series to show, but because of time, I sort of took that out. But the bottom line is with Kristen, she does have a high smile line, and she's had a history of endodontic therapy, and she still has pain on those maxillary incisal teeth. And the question really becomes, it's not about endo versus implants, it's really about logistics. And I've always told the endodontist, if you're going to charge the patient, and is there any endodontists here? Because I don't want to put my size 13 foot in my mouth. I want to be somewhat responsible. But is anybody an endodontist here? And I've told the endodontist, I said, if you're going to charge the patient $50 per retreatment, have a nice day. Do it as many times as you want. Because the risk-benefit cost ratio is very low. It costs $50. But once you start charging patients thousands of dollars that are comparable to implant therapy, you have to weigh out the risk-benefit cost. It's really a cost issue. So in a lot of these type of situations, we replace these teeth in lieu of implants. What's going to help us in Kristen's situation, even though she has a high smile, is that these teeth have erupted. She has short teeth. And consequently, the interproximal papillae between the two centrals has also erupted more incisal, as well as the midfacial. These teeth are short, so if we get a little recession, it's actually going to work to our benefit. So she's actually an ideal candidate for this type of therapy. Again, the question becomes endodontics and being able to restore these teeth. We like to do a flapless approach. A lot of the studies by Queerman definitely shows that a flapless protocol is the best. Be disciplined, learn how to extract teeth without laying a flap, because you want to maintain the blood supply as well as the anatomy. That's the key with immediate therapy. Again, all the studies done by the late Cy Evian, who unfortunately passed on, talked about proper socket debridement. And if you can't debride the socket properly, you're probably going to have an increased incidence of implant failure by about 5%. So the real surgeons know how to remove teeth without laying a flap and doing proper socket debridement. That's the discipline. Then implants are placed more to the palatal aspect, as seen over here. Dennis actually placed the right implant at 3 millimeters from the midfacial crest of soft tissue, according to Lyndon Cooper's 3-2 rule. 4 millimeters for the left central, because we wanted to actually get the gingival level at the same height. So you have to strategically plan these patients to understand that if the tissue level is at a different level, you have to plan accordingly. We do use this shell. The shell is just a preformed sleeve that allows us to capture the soft tissue shape, because after tooth extraction, the gingiva does collapse, and hence it saves time. It probably is going to save time for the surgeons who are not accustomed to making provisionals. I just did a hands-on course with Lars Hansen, and the key is that if we had something like this, we could save time. It does come in a venti size, so we can make it into a grande or tall, because we don't have a consensus in implant placement. I'm an Ernesto Lee believer. He says 4, Dennis says 3. I can tell you it's between 3 and 4. All right? It's somewhere in between there. We don't have a consensus, unfortunately. And I can use this, again, the collapsed tissue can be brought back to its pre-extraction state. We can compensate for eccentric implant positioning by then putting these cylinders on so the implants are placed more to the palate. We can contain and protect their graft by relining these all together and then filling in the dots outside the patient's mouth so that we've trimmed up a provisional. It's done pretty quickly. It's not a hard thing to do. We always make the provisional first in the dual zone technique because we're going to place the graft into the soft tissue zone. So having the acrylic in the soft tissue or the composite, it really doesn't work. So that's why we always make the temporary first. And again, the dual zone technique of intentionally placing the bone graft into the soft tissue and then containing the graft with a provisional restoration. Paul Weigel published this 7 years ago. He called this the prosthetic socket seal. It works really well. Again, this is how the patient would leave our office. This is what it looks like after 1 week, and we do wait a long time. Now, she waited a little longer because she was comfortable with her provisional, but I would recommend that you wait at least 6 months for soft tissue maturation. It's understated the importance of maturation, and I think companies are too eager to get us to rush to failure, and I'd rather wait for success. So we're a little bit cautious. We do wait for maturation, then we can disconnect, make an implant level impression with pattern resin, and then pour up a cast. So we wound up, I'm at the try-in stage, but you could see here that we've lost a little bit of papilla height, but we still have the scallop. It's roughly 40% the length of the tooth, so quantitatively, it sort of meets all those criteria. Again, in this situation, we actually made her a new provisional because the existing provisional was out of occlusion, so we made a new provisional in occlusion. I learned this from Ernesto also. Patients have a hard time adjusting to an increased length of tooth length. So it's better to test it out on the provisional to make sure they're okay with it. We also contoured the provisional a little bit more according to Weisgold to stretch the tissue a little bit more. So we increased the length and we wanted to evaluate it. So she's now in the phase of doing the metal try-in. But everything is sort of set up. You can see the papilla heights are all equal. We had a little bit of luxury with that, so there was a little bit of play. We felt that even though she was a high-risk patient because of her high smile, there was a lot of things working in her favor. The reality is you do lose a little bit, and we'll talk a little bit about that afterwards. How about a more challenging situation with 2 implants next to each other for central and lateral? Now, this is Kevin. Kevin basically had been a basketball player in college, and he had really caught in a lot of elbows in college. He's sort of a big, burly guy. He's almost like Charles Barkley type of player. Maurice, actually, if you didn't know, played for Rick Pitino when Rick Pitino was the coach at Binghamton. So you can tell that Maurice was a really good basketball player as well as Henry. I don't know if Eddie played as well, but I spoke to Henry. And Henry said in his day, you know, Henry's, okay, about 6'1", 6'2", but Henry told me he could jump like a rabbit and he could dunk the ball. So that's sort of the history. Well, Kevin also was a basketball player, but he didn't wear his mouth guard, and hence over the time he caught a lot of elbows or he ate a lot of elbows, and this is what his teeth look like after some time. So you know that Kevin's going to lose these 2 teeth because they're going through resorption. Now, if we analyze Kevin's situation a little bit more, he has an extruded left central incisor, or it's maybe ankylosed or whatever, and the papilla heights on the left side of his mouth are already more apical and shorter, and they're not even showing. He has a very, very low smile line. He has a low aesthetic IQ, and he has low aesthetic needs. He's a perfect patient for this type of treatment. Totally. Low demands, okay? And he has more tissue on the left central incisor. So Kevin, great guy, no problem. Doesn't show the papilla. They're already shorter on the left side. So if we lose a little bit, what's the big deal? Okay, so again, this is the days I'm in the lab sitting there. You know, Dennis, let's be honest, they're really great surgeons, and all of you guys are great. You could slick a tooth in 5 minutes and put an implant in another 5 minutes, 10 minutes maybe, right? And then the restorative guy like me is there for the next hour making the temporary. Not on these days. I was in the lab and I told Dennis, I said, is he done yet? It's been 40 minutes. And he's still working at it because these are tough cases. These you sweat. This is the real surgeons that have to be disciplined to remove every remnant of infection and not lay a flap and place implants in a more favorable position, more to the palate. Again, we can use the shell as seen over here, so you've seen that, so I'll go through it quicker. And then we can make our provisional and we do staining. We don't stain the subgingival part because I'm just not sure what will happen, but we do use this OptiGlaze color, which works quite nicely. Again, it's out of occlusion, it's non-functional, and then we do the dual zone grafting technique like I showed you before, and then replace the temporary and just let things sit. That's the key. Just let it sit. We wait for 6 months. Then we can disconnect and make our implant level impression. We can even use the shell to help us join the shell to the implant level impression copings. Adam can then go ahead. He just made 2 metal ceramic single unit crowns. And you can see here. Now this is not a good result because he already had shorter papilla, but you could clearly see here that the papilla is definitely shorter. Again, he has low aesthetic needs, a low IQ, and he's an easy patient. He was just happy to have teeth. But let's analyze this a little bit more. If you look at his preoperative situation, he clearly has lost a little bit of papilla height. Now, also what would have helped the cause is the following. If we had stretched the soft tissue through restorative contour of the left central incisor, the papilla would appear taller in height because you can play a little game called the papilla game. Because if you cover the root, you'll shorten the papilla. If you crown lengthen midfacially, you always increase the height of the papilla. So that's a little trick that some people play. But if I look at the preoperative casts and I compare them then to the post-treatment cast, you can clearly see he's lost about 0.5 to 1 millimeter. But that's not the true story. The true story is the quality of the papilla is poor. And I just saw Eric Van Doren talk about that at the Ceramic Symposium. And he talked about not just the height, but the quality of the papilla is usually what's missing. You're losing the buccal volume, and that becomes a problem. So I agree with Eric that it's not just the height, it's also the quality. I think that's really important. And if I go back to, say, Kevin's case, and if even I go back to Kristen's case, we forgot one important ingredient. We forgot to put the bone graft interproximally and apply the concept of dual zone to interproximal dual zone grafting. See, we were so focused on the buccal and getting the buccal to collapse, we forgot to add the graft interproximally. That's where the mistake lies. And that's where the learning process is in this whole discussion. So if I can then go back to, say, looking at another patient who's going to receive potentially an implant and a pontic, we clearly want to then adopt what we understand, but carry the dual zone grafting to the interproximal. I think that's really the messaging. Now, if you look at the classic literature associated with pontics, a lot of this work has been done. The first papers were published in 1918, and Lenny Abrams, the great Lenny Abrams, who was very close with David Garber, and David Garber with Ed Rosenberg had also published a lot about pontics. I think that's really something to be interested in. But there has been a resurgence of pontics, and especially ovate pontics, since 2009. And I know Alessandro is speaking in the meeting. Did he speak today or is he speaking tomorrow? In February at the symposium, at the big symposium, Alessandro Panzi, who published a book, The Fundamentals of Implant Dentistry, with Peter Moy and this other doctor, also published papers on using pontics. And recently, Maurice and Howie Gluckman in South Africa have also published pontics, but using the pontic shield. Pontics are sexy and they're in now because they're useful. They're really useful. They work. They really work. Dennis actually just published some information to look at this with a group from Colombia. And Dennis told me, he goes, do you understand that people have been using pontics since 1918 and no one's looked at numbers? No one's looked at recession or collapse? Well, Dennis did get one of the graduate students to look at this. And he found if you just extracted a tooth and put an ovate pontic, how much recession you would have, midfacial recession, and how much collapse you would have. About 1 millimeter. And this study was a short-term study, but it was without socket grafting. Marco Esposito, I don't know how they say it in Italy, also did a study, and he only looked at the PES score, the pink aesthetic score. They didn't look at ridge collapse or recession, but they did show favorable outcomes with socket grafting. So you would imagine with socket grafting, this would all really help the cause. And of course, we know this classic paper from Team Atlanta that talks about, using implants versus implants, but these were implant to implant that were in healed ridges. We need to redo the study, Maurice, with immediate. So that's the data we need to get. And then implants with pontics, they showed that you have the potential to preserve more vertical tissue height if you have a pontic. So again, some of the things we have to manage prosthetically is the following. When you extract the tooth, you have an immediate blood clot that fills that area, and you have peri-implant soft tissue collapse. It occurs very quickly. By the time I get to the patient, there's a liver clot there, and one of the reasons why I went to Seattle to do pros is so I wouldn't have to do surgery. Ernesto was supposed to be my classmate in Seattle. He stayed at Penn, and he's a terrific surgeon. So that's sort of the little history. I've known him for 30 years. But the socket bleeding, so how do I manage this? And the problem is when you go and you try to reline the pontic in tissue that already has a blood clot there and the tissue's collapsed, you never get a nice peripheral reline of the socket because it's already shrunken, and you usually end up with voids, even after a couple relines. And I relined that pontic about 2 times and I'm still getting voids. So the real key is, can we do this more in a prefabricated way? Now my partner Dennis calls this POP. He calls this the prefabricated ovate pontic because they look at little popsicles. And Dennis also has a thing for desserts. So he has the ice cream cone. No, I don't want to say that. But he does like the ice cream cone technique. So he goes, Steve, this fits perfectly because even in type 2 sockets, we're combining ice cream cone with iShell, or we're combining it with POP to treat some of these dehiscence defects. It's much more sophisticated, but we are using this. He goes, it looks like an ice cream pop. So he likes calling it the POP. So the last patient I just want to share with you is Sophie. Her chief complaint was that our left central incisor was actually discolored, and that was sort of what brought her in. Now, if you notice with Sophie, she has a thin periodontal phenotype. She also has recession on the left side of her mouth. And hence, because she has recession, she has a taller papilla. As I said, you want to make the papilla appear longer, just do midfacial crown lengthening and don't alter the interproximal. And you can see here with just recession, that papilla is taller. It's not 40%, it's like 50% because of the midfacial recession. So she has some issues, and she shows the papilla on smiling. And she also has these 2 teeth due to trauma that are really non-restorable. So these are some of the problems that we have to manage in these situations. Again, atraumatic tooth extraction, if it's there, leave it alone. Again, Dennis uses these burrs from Brasseler to try to create a purchase, and he tries to go in there and clean them out and extract these teeth atraumatically. We are going to be placing a single implant on the left central and then using an ovate pontic on the left lateral incisor. So we can use the shell for the implant and the POP for the left lateral incisor. Here it is. You could see that just because of the shrinkage of the peri-implant soft tissue, that it's like, look, mom, no hands, because you can just stick the things in there and they just stay because the tissue has contracted around those sites. What I can do here again with this type of clot is that I can put the POP in the place. I can then lute the component of the shell to the existing manufacturer's temporary cylinder, and then we can pick up that POP with the reline of our crown and bridge work for a provisional. In fact, if I had to grade myself, I didn't do such a great job of relining this provisional because you could see the POP had actually moved and migrated a little bit. The key is the following. The part that's touching the subgingival area is done in a prefabricated way and it's smooth. And that's the hard part. I can then add to these voids outside the patient's mouth and just trim it up. It's not a big deal. Now I've created something that's done in a prefabricated way. Dennis, again, can do a dual zone technique, but the key is doing the interproximal dual zone, carrying the graft interproximally as well, being conscious about that, and then containing the graft with the provisional. It's the same thing over and over again. I'm just doing it with a pontic. Here it is at 5 months. We can disconnect our provisional restoration. You can clearly see here a little bit more the shape of the soft tissue. Again, the net papilla height, because we actually under-contoured the temporary and we actually encouraged the tissue to come more incisal, is actually shorter But if I left it in its existing position, I would say the height we probably lost a little bit, but the quality is clearly better because we had consciously placed the graft interproximal. I can then paint in, again, with some pattern resin in this situation, capture the pontic with the subgingival contour. We can then put it back into the impression coping and make an accurate soft tissue cast. Adam can then go ahead and make a screw-retained metal ceramic crown. We were able to clean this area seen over here. Again, this is about the interproximal so that we could get the graft material. You can still see the graft material a little bit interproximally. And the reality is we did lose a little bit of height. It's something that you can't avoid, but I think it's still a fairly reasonable result for a very difficult situation. So again, if we looked at 2 implants delayed versus 2 implants immediate versus immediate implant with an immediate pontic, I think we have the ability then to maintain a lot of this architecture. Again, if it's there, leave it alone. So what are the conclusions behind me talking for the last, say, 45 minutes? The key here, I don't know what happened with this thing. Sorry about that. Hold on a second. All right. The key here with this is the following. With the implants, the key is the platform switching. I think platform switching really helps in regards to actually being able to maintain the tissue. If you place the implants deep enough like you are with immediate implants, I think platform switching really helps. The key is that with the platform switch, you can actually then maintain the soft tissue architecture because you can get the seal. But the key is you need to be able to have enough tissue there, and the dual zone technique really helps with that. We believe that adjacent implant sites can be treated with immediate therapy. I think that works really well. You can do it in a sequential manner like Joe Kahn showed as well, or again, as an immediate matter, so it could be done sequentially or in an immediate matter. Again, you can use the interproximal dual zone. I think that's one of the key elements. We're sort of missing the concept that interproximal dual zone should be applied in these situations because we know that we can thicken the tissue normally with just putting the graft there. And I think implant-pontic relationship should not be underestimated when we're trying to manage and deal with adjacent implants in the aesthetic zone. And again, we have to allow for maturation for at least 6 months because I think that maturation is a very important concept that is somewhat overlooked in this whole discussion. What do I think is the future in regards to this topic? Well, what I think is the following, is that the effect of immediate implant therapy with platform switching is unknown. We need to do more studies. We need to redo the 2000 study that Dennis did with Team Atlanta, and I think that's really the future of what we're looking at. What is the ideal amount of platform switching? I don't know anybody who has done that research to actually identify what is the ideal amount. Canullo showed more is better, but we still need to know what is the ideal amount. Can a laser microtextured surface implant abutment system actually help in this whole cause? And again, how much gingival augmentation in situ can occur just with the platform switching design, which means how much soft tissue can grow in horizontally without suffering any changes in ridge contour. I think that's important. Again, what is the metric outcomes if we use the dual zone technique with interproximal bone grafting with immediate therapy? I think that's important. And what would be the metrics of the papilla height with implant pontics with also immediate protocol? And again, if we're talking about then managing the restorative contour, it's not just the midfacial contour, we also have to factor in what is the ideal interdental contour. So with that, I wanted to, again, leave you with this, again, the last piece, which again is looking at some of these different situations. I want to thank everybody for attending.